safety and reducing harm. And that is, we have to create a culture within our countries and with our organizations where we first support the care providers in the amazing work that we do. And if we do not do that, I don't think any of the rest of the strategies that are going to be talked about during this meeting are going to be effective or be successful. So let me just launch quickly forward to what I consider to be an example of a case that drives this home. This is a real case that I learned about that actually happened in the state of Maryland. And it was a 73-year-old gentleman was in a cardiac intensive care unit. And he had a moment of developing a dysrhythmia that needed immediate defibrillation. And when they attached the defibrillator to the patient and the nurse went to activate it, it totally and inexplicably shut off. And this is an open organization where they encourage people to make variance reports. And so the nurse put the report in to say that for reasons completely unclear to her, the device did not work. This is the device. And this is how it's supposed to work. As you can see, you attach it to the patient, you hit the on button, you then select the amount of energy to defibrillate the patient, you then charge the device, and then you shock the patient, and they should get into a perfusing rhythm. But when you look at human factors and you look at what life is like for a nurse in an ICU, and the way nurses throughout the world are trained, we are trained that green is good and red is bad. So in the heat of the moment, she turned it on, she selected the energy, she charged it, and hit green. And what happens when you hit green on this device? It shuts off. And it takes 3 minutes to power up. At a time when we know that time is life in somebody with a dysrhythmia. And so when you take this device and you put it in simulation, 20% of the time a nurse will hit green instead of red. It is an absolute disaster design system problem. But imagine the nurse who discovers that this is what she did. How horrible she feels. How in some organizations the culture would be such that she would be fired for hitting the wrong button. And we have to change that approach to healthcare. And fortunately now, through a lot of the work I've been involved in for the last 15 years, especially the last 5 years, through the work of the Agency for Healthcare Research and Quality in the U.S., we have built a very organized program to help every hospital in the U.S. at least, and now in Doha, Qatar, where I work, to build programs that can immediately respond when events like this happen to support both patients and families as well as the caregiver. We are trying to follow the just culture example, where in a case like this, as you look at this diagram and you think about this nurse and how we should approach her, she did not intend to turn that device off. There was no evidence of illness or use, as you can see as we move from the left to the right. She didn't knowingly violate a safe procedure, and this could have happened to anybody. And she has no history of unsafe acts. That was absolutely a blameless error. She needed a hug. She did not need to get fired. And we need to think about creating approaches like this, standardized approaches like this, so every time there's a harm event, we consider the fair and accountable culture, the just culture, so again, we can help our care professionals in this. So when is support needed? It's needed when almost anything can happen in healthcare, whether we make mistakes or not. And in fact, we need to take advice that we've learned from this fantastic article about what I learned about adverse events from Captain Sully. You probably all know who Captain Sullenberger was. He is the guy that flew that plane out of LaGuardia, ended up hitting a huge flock of birds, and ended up having to land that plane in the middle of the Hudson River, and nobody died. In fact, nobody was injured. And when Sullenberger was interviewed by healthcare people to say, what did you learn from this event? He said, the most important thing we learned is how we in aviation respond when an unexpected event happens. And so you learn after this miracle on the Hudson that the person most affected emotionally by that was the air traffic controller, who was watching that plane and what he thought was going to crash in the Hudson River and everyone would die. And so immediately taken off the job, was not allowed to go back into that tower, would never have been allowed to track another plane and plot another flight out of there. Flight crew members, some of them never returned because they were so affected by this. And of course, unlike what we do in healthcare, it was a key debriefing of everybody in 24 hours. So let's think about, what do we do in healthcare? 1987, I'm working in the operating room at the Brigham and Women's Hospital. I have an unexpected death in the operating room of a 25-year-old, my age. And what do? I come right back in the operating room, 30 minutes later, put my next patient to sleep. I'm not sure that's safe. I'm not sure that's the kind of environment we really need to have in healthcare. And so many of us are felt and left extremely vulnerable when these sorts of things happen. And so we know the outcomes can be very, very significant. There's an article that was written about those of us in anesthesia, published in 2008, about those of us who were involved in these perioperative catastrophes. It is a very sorry state that those of us in anesthesia have twice the incidence of suicide than almost any other profession in medicine because of all of the death that we see, even though it occurs when no mistake has happened. And so we've now really begun to understand the value proactively of building systems in our hospital to teach and train people how to have difficult conversations and how to actually support each and every one of us every day we come to work when these unexpected things happen. And so there are many ways to care for the carers. There are systems to provide immediate first aid. In fact, the system that we developed at the University of Illinois that we've now implemented in many systems in the U.S. allows for an immediate response to patient harm events that includes simultaneously hugging and loving the patients and families through these events, as well as the caregivers, so that we can move quickly from harm to healing, and we do not allow over time for our caregivers to get to the point where they themselves also suffer from post-traumatic stress syndrome. Every step along the way, identifying, recognizing there are many different ways that we can begin to do this. And so we have created immediate peer-to-peer support teams that again are available 24/7, where physicians support physicians, nurses can support nurses, again when they're involved in these unexpected events that we've heard about. And so we've done this. We've created tools that will be available on ARC's website that looks at building a clinician support program, a step-by-step program that any hospital can embark upon so that they too can create this piece with a checklist that shows how do you begin to go through every single step here so that you are able to build this kind of program, again, as I would say, a condition predicate to moving forward on your patient safety journey. The benefits of this, it is providing that immediate emotional first aid that we all need. It restores providers to their professional role where they can provide, again, effective care, and it's absolutely essential for establishing a just culture. If we're going to have nurses, like that nurse in Maryland, feel confident when she puts in that variance report, we have to make sure that we respond to her the same way the MedStar system did when that happened to her, where she gets a hug, she gets consoled when that happens, when she hits the wrong button, and then they go back to the drawing board to figure out how do we now redesign these defibrillators. And so many of the organizations we worked with have put amazing programs forward. This is a poster that is now up in almost every unit in the Dignity Health System in California, where they have 40 hospitals of various sizes. And they call their program very simply, We Care. We care for our patients and our families and our community and our country. And we also care very, very much for our care providers. We are here for you. So thank you again for giving me this amazing opportunity to speak at this plenary session. Again, I want to thank the Wish people for inviting me to join their incredible team for what they're doing around the world, and I thank the Apollo Hospital Group as well for this opportunity to have just a few minutes with you. Thank you.